kill you guys on oxygen. We're gonna talk about that again, we have to. So nitro, aspirin would be the things. What would you expect related to their, to the response to your treatments?
The
What's that?
ST
Less pain.
Yeah, you'd expect improved response.
would you expect to see that ST depression go away?
Why would you expect improved response? Yeah, because we're introducing perfusion.
Yeah.
As we introduce perfusion to them, what's gonna happen to their ischemia?
It's gonna go away.
It's gonna what? It'll be less ischemic, right? And what is the x-axis on EKG?
Time.
Time. So if I have one moment in time where the tissue is ischemic, and a different moment in time where the tissue is not ischemic, what will I notice as a difference on the EKG?
No more ST
Return to
depression.
normal.
Because the ST changes are acute changes. They are showing you what is actually happening in real time at that moment.
Isn't that why you want to get a 12 lead before you give nitro, so you can catch that?
Which is why we talk about getting 12 leads before we do any sort of reperfusion if possible, right? Now, if that continued and we didn't take care of it properly, or the angina wasn't just an anginal attack, but they actually started having injury to their heart, then it would come over here and we'd see that ST elevation that started to occur. Because injury is now taking place rather than just ischemic tissue. Does that make sense?
Yeah.
And what would we see as a potential difference in our response to our treatments?
Nitro or aspirin don't work.
Yeah, nitroaspirin would be less likely to provide them relief of pain, right? Maybe we're even giving them a narcotic now, but we'd still have less of a response to that than we would have if they were just angina.
Do you expect some response?
You might expect some, especially when you start adding the narcotic to the mix. But we're still having a situation where it depends on the blockage, how large that blockage is, right? Before we find out how much response they're gonna have. Yeah.
Would we expect that?
So if that ST elevation was not as high compared to it being higher, would that depend, or would that influence how much effect nitro would have on them?
Not necessarily.
Okay.
That's completely, so the level of ST elevation is more in response to how much tissue for that particular view of the heart that we have, that we're actually seeing. But whether that tissue is going to be responsive or not to our treatments has to do with the level of blockage leading to that heart tissue.
Would our pain management narcotic help with just pain, or would it also help with perfusion through?
I mean, they have, depending on what narcotic you use, it has some vasodilatory effects, but
Not-
it's really the pain management that we're looking at that point.
Not compared to nitro?
Yeah, I mean, nitro is the biggest vasodilator we have. Okay, so.
We're gonna talk about oxygen?
I'll just tell you that I am not being kind to you guys on oxygen, and I will never be kind to you again on oxygen. And I'm noticing that on your EKG exams right now, where some of you are just willy-nilly giving oxygen. Stop. When do you give oxygen?
If it's below 94%?
When they need it, right? And our SpO2 should be below 94 under most circumstances. In heart conditions, they actually would need to have a lower SpO2 before we're really dying to give them oxygen.
I was reading an article about how they're showing oxygen actually acts as a constrictor,
It is.
vasoconstrictor
It is. In systemic vessels.
in systemic vessels, yes. So it could hurt them more than,
So,
Yeah, we can.
well,
go-
not help them, I guess.
I can take you down all different type of pathways that show oxygen is not the best thing to give in situations where oxygen is unneeded.
so I'm just gonna ask, because I'm gonna get beat up for it, but I'm gonna ask anyways. you have a ischemic, tissue that is not getting oxygen, maximize oxygen. If I increase the percentage of oxygen getting to the blood, wouldn't that increase the oxygen to the tissue?
Dustin's asking the question.
I don't like it.
That's fine. I knew I was gonna get beat up.
Those two words do not mean the same thing. What's the difference in those words?
Lack of oxygen versus lack of
What does that mean? Give more information.
So
Yes, you're right.
In hypoxia, you might be perfusing just fine, but you don't have oxygen, as much oxygen in your blood.
Okay.
And ischemia, you have tons of oxygen in your blood, but you're not perfusing.
Why aren't you perfusing?
So the
Block it.
Gotcha. So there's plenty of oxygen in the blood.
Does that make sense?
Yeah.
Hypoxia means a lack of oxygen. Hypoxic tissue means that that tissue is not getting oxygen. Ischemic tissue means that tissue is not getting blood supply,
Gotcha.
right? Now, ischemic tissue is hypoxic, but it is hypoxic because of ischemia. It is not hypoxic for some other reason. So if the blood is not hypoxic, meaning if the blood does not have less oxygen than it's supposed to, then it's not the blood's fault, specifically speaking, that this tissue is not getting its supply, right? So if I have this tissue right here that is being supplied by this capillary bed, right?
Mm-hmm.
And this capillary bed, my partial pressure, my PO2 of the capillary here, my partial pressure, my P little a, arterial flow of the capillary right here is, let's say, I don't know, let's say 62 millimeters of mercury. And that is because they are at altitude. That tissue is hypoxic. That tissue is not ischemic.
Got it.
It's got plenty of blood supply. The blood supply that it's getting, though, is hypoxic. Does that make sense?
Mhm.
But if I have a blood supply here that has a PO2 of the capillary of 98%,
Giving more oxygen is gonna make it better.
and there, don't, Mon's about to hit you. I can see the anger in his face after what you just said.
Yeah.
So 98% of the blood supply right here,
Here it
that
comes.
oxygen is fine, right?
Yeah.
The blood supply is fine, but we have a blockage. That tissue is hypoxic.
Because it's,
Yeah.
That tissue is hypoxic because it's ischemic.
Got it.
Does that make sense?
mm-hmm.
Providing this blood with more oxygen is not going to help that tissue. But it will have an effect on the blood vessels, causing constriction, which makes even blood supply to get there even harder. And it will increase the PO2 above 98%, above 100%. And as it does that, we start to increase our reactive oxygen species, which are toxic, which means
We
now
increase
have
what?
our reactive oxygen species,
What's that?
hydrogen peroxide, superoxide,
Okay.
oxygen reactions, that then are now causing more acidic and waste product environments that cause this tissue to be even worse, because now it's already damaged, and now the blood supply that is getting there with toxins in it, which is making that tissue even worse.
Got it.
Does that make sense? You guys must keep the difference between hypoxia and ischemia clear in your head, because there is a difference. And in 40 years of EMS, we equated those things, which is why every cardiac patient on the face of this planet since the 60s on up have always gotten a high flow oxygen. But it's not right. And it's been changed, or it is in the process of being changed, but you gotta get past that, right? Okay, everybody clear on those two things?
You're welcome for asking it.
So if we're dealing with a patient that has, they're going through a cardiac event, we've always had the mantra of 94% below giving them oxygen, but we should be hovering down even low 90s if not high 80s.
If they're in the low 90s, most likely I would prefer if we were giving them a nasal cannula rather than a non-rebreather.
You can give them some O's, but just don't slam it into them.
We've seen in the research studies that we've done, we've seen that really it takes an SpO2 below 85 before we really should be giving oxygen to cardiac patients. And a lot of hospitals have started to move towards 88 as being their guide. So if someone's on a ventilator with a cardiovascular problem, they'll most likely put medical air through instead of O2 to help ventilate their lungs until their SpO2 drops below 88, and then they'll start putting oxygen on.
Is that because a lot of those patients,
Which was what?
I don't know, but they had wasn't a valve replacement, they had like a mesh something on their heart, and I don't know exactly what it was, because I wasn't in that long, but that the blood pressure in the heart was getting high enough where it was starting to tear that mesh away. And so they had to maintain a very low blood pressure, like in the 70s systolic, but they're about to put him under to go into surgery, so they had to maintain a higher blood pressure to make sure he didn't pump during surgery, but they couldn't go too high. But then they were starting, when we ventilated the patient, they were not gonna put him on oxygen because they didn't wanna take his oxygen levels too high, because they were trying to keep him in the 80s.
Yep.
So it was a weird,
Interesting.
weird case.
I'm glad you saw that. Make sense?
That was my blind spot. It was good.
Okay, so here's the deal. Okay, so you know what to look for to find out if the patient is ischemic. You know what to look for if the patient is currently being injured, which we refer to as what?
infarction,
Am I?
An MI.
and
right?
AMI?
And you know what to look for if the person already has heart death.
A Q wave.
Good? So you know what to look for.
Pathological.
Yeah, right, Mom?
So for MIs that happened years ago that pop up, that'll show the Q wave that you're talking about.
Yeah.
So if I ask for history, like, oh, I had a MI 2 years ago, and you see like the pronounced
Correct.
Q wave, like, oh. yeah.
That's right. You do
Makes
correlate
sense.
those
2 and
dots.
2.
Yeah, I'm
Push it
smart.
there.
Okay, so now you know what to look for, which is easy. That's the easy part, right? Now what you have to apply to that is where is it happening? And that's where the 12 lead comes into play. The 12 lead gets to tell you where it's at. In order to know where that is, you have to clearly understand where you're physically placing your electrodes and what those electrodes look at. That requires you to do two things. One, what I just said, know where you're physically putting the electrodes. And two, make sure you understand the anatomy and the orientation of the heart when it's in your body. Does that make sense? Knowing that the right ventricle is anterior and the apex is off to the left. You have to know the orientation and anatomy of the heart in the chest cavity so that when you put the lead physically on their body, you know what it's looking at. Does that make sense? It also means you have to, and I know that this is becoming a struggle for a few of you, you have to understand the triangle that's created by our limb leads, right? So we are putting our limbs, our lead, this is right and this is left, right? We are physically placing the leads here, here, and here, right? With the ground being over here. That's where we're physically placing them. But because of the anatomical orientation of the heart, you have to understand that those make an equilateral triangle that looks like that, right? When we look at it this way, it makes it seem like our triangle looks like that. but it doesn't. Anatomically, it's shifted so that the point is directly below the heart, electrically. Does that make sense? And furthermore, you have to make sure you understand that when we say the triangle's like that, when it comes to the heart, we actually mean the triangle is like this, through the heart. This line doesn't look above the heart, it looks directly through the middle of the heart, electrically speaking. Does that make sense? Those are the things that you have to kind of put into play. And then, lastly, you have to be able to name them. You have to know that the camera that's sitting here is the lead 2 camera, the camera that's sitting here is the lead 1 camera, the camera that's sitting here is the lead 3 camera. Good?
Yeah.
We take that one step further. Because we have 3 wires, we can only have one wire be the camera. We can't confuse the system and make 2 wires a camera. One wire has to be the camera. One wire has to be a negative, and one wire has to be a ground. But if one wire is the camera, and we have 2 available wires left over, we can just force them both to be equally negative. And our camera is a magnet, where its view is always focused at wherever the negative is. Right? And if we have a camera sitting here, looking at a negative here, and we make that negative also, then this also is equally drawing that camera's view too. And the camera can't point this way because this is asking for it to come over here, but it can't point this way because this is asking it for it to go over there, so it points down the middle. Does that make sense? And that gives us our augmented view. Say again?
Can you draw in red?
I can. Right? If both of these are negative, and that's my camera, then the camera is drawn equally to both of them, and it centers it. And so we see that view. That make sense? Or same thing, if this is my camera, and both of these are negative, then we see that view. AVL. And if this is my camera, and that's my view with both of these being negative, then we see that view.
Okay, so obviously the star shape is more important, but can you draw an equilateral triangle that is then created
Of the AVR.
With these ones,
with augmented leads?
you can expand all of those back out in the same way that we expanded the other ones back out. And it's the same equilateral triangle situation.
Yeah, can you draw it?
That would require me to see where the points are.
Because I can't
Wouldn't it just be
visualize it
revert-
unless it's like
Would it just be
creating a
reverse
star
out
naked.
equilateral?
No.
You know what I'm saying?
No, it wouldn't be sideways?
It'd be
No, you're-
sideways.
It would?
Yeah.
Okay, never
It would
mind.
look the same as sideways.
Yeah, it'd be like if you
You'd
took that
shift
one
your-
and
Yeah, six-sided
rotated
star.
it clockwise,
Is what you
clockwise
mean.
90.
So,
Yeah,
however it goes
and then straight down.
Okay.
into your triangle.
Wait, how did
No.
that bottom?
Yeah, I was about to say,
yeah.
wouldn't it be like
No.
we took the
It'd
blue
be
one and
shifted.
rotated it
I
90
think
degrees?
it'd be fine. It's just a six-sided star. That's all it is.
It's like kind of crooked though.
Well,
It'd be more like,
because that's just what it is. And that's what you need to focus on.
and that-
Good? Are we good so far? Questions? Let's begin with it. Okay. So then it's memorizing